All right. Well, good afternoon and good morning to everybody. It's great to see about 84 people already on the call. This study, of course, just recently activated, so I think this is a terrific turnout, and we are recording this, so it will be available afterwards. We wanted to talk about the trial and its activation, its timeline, where we are with the current study, and I'll give some introduction on the study itself and the inclusion and the rationale. But we really wanted this to be practical. This trial is different than most trials that have been conducted in NRG oncology and really all of the cooperative groups to date. So the treatment planning aspects are unique, and so we wanted to give some practical examples of how you actually plan these cases. So Josh, my co-PI, will then be going over some representative cases that have come in on the study to date, how they were contoured and how they were actually planned. So with that, we'll start. Again, we're talking about LU008. This is our phase 3 prospective randomized trial looking at SBRT to the primary tumor, followed by concurrent chemoradiation to the mediastinum for patients with locally advanced non-small cell lung cancer. My disclosures are NIH funding and varying medical systems. So we have an amazing study team. So Levin Cancer Institute, very well and rightfully represented. I'll explain why in a minute, that they've really led a phenomenal phase 2 study. Josh is the co-PI and Catherine as our medical oncologist. Jeff Bradley, our chair of the thoracic committee, is a co-chair as well. And then Emory with Kristen Higgins in radiation oncology and Liang Lin as medical physics. And we have great translational support from Mohammed, NCorp and PRO, quality of life support from Nori. And then Chen is our terrific statistician from NRG Oncology and Hopkins. So why are we doing this study? Why consider changing the paradigm in treating with SBRT and locally advanced non-small cell lung cancer? Well, we know, unfortunately, our outcomes for locally advanced non-small cell lung cancer are not great. Historically, we've only had about a 15% 5-year overall survival. We've only controlled the tumor 50 to 60% of the time as the primary tumor. That was pre-Pacific, and now with the addition of durvalumab, we do better. Our 5-year overall survival has really jumped to up to 40% in people that can tolerate durvalumab. That being said, progression-free survival is still only 1 in 3 optimal durvalumab patients, and local control really remains poor. Primary tumor, in fact, is actually the most common site of non-metastatic failure, and we really do have an unmet need for trying to figure out how we improve local control. And that's important because we know that local control drives new distant metastatic disease, and it's very predictive of cancer-related deaths, and certainly correlates with overall survival. I want to draw attention to 2 studies in the locally advanced patient population of why local control really makes so much of a difference. One, many of us are radiation oncologists, we care about local control, but what we do really impacts survival. In the opera meta-analysis, this was looking at 1,200 patients, looking at sequential versus concurrent chemoradiation for locally advanced non-small cell lung cancer. By doing concurrent as opposed to sequential chemoradiation, there was no improvement in distant disease, but there was about a 6% improvement in local control. That led to a 5% improvement in overall survival. So nearly a 1-to-1 improvement. If we can prevent a local failure, we save that life, and we can prolong survival and likely cure those patients. A great analysis was done by Mitch McTay, looking at a pooled analysis from 7 NRG RTOG trials. Here, local control was associated with overall survival on both univariate and multivariate analysis. And in fact, if you look at all the factors that we know are prognostic in locally advanced non-small cell lung cancer, whether it's age, performance status, histology, PET staging, etc., local control was actually the factor most correlated with overall survival. So how do we improve local control? Well, one way that it was done in early stage non-small cell lung cancer was to use SBRT. Here you can see by treating to a higher biological effective dose, local control can significantly improve and pretty dramatically. This is a BED of greater than 100 in early stage patients, whether it was delivered in 5 or fewer fractions or not. If you treat to a high biological dose, you have excellent long-term local control. If you don't, you start to have a significant drop-off by the end of year 1 into year 2 of your local control, and that directly ties into a loss of survival with the lower biological effective doses. So can we use that same concept and use SBRT in the locally advanced setting? Well, we're not the first to think of this. There have been a couple of groups that have looked at using SBRT before, but all of them have used SBRT as a boost as opposed to primary treatment. The University of Kentucky was one of the earliest to do this, looking at 35 patients prospectively. They treated all patients to 5940 and then gave a 2 or 3 fraction boost with SBRT to the primary tumor, again, owning the fact that primary tumors are a site of most common failure. Unfortunately, that was a pretty toxic endeavor. They had 2 patients die of fatal hemoptysis. Georgetown retrospectively did this on 16 patients. They did seem to make headway with the local control and overall survival at an early time point in a small retrospective study. Prospectively, Brown and Emery also looked at this, and Brown's experience, 1 out of 12 patients had a high-grade complication. And similarly, in Emery, they had tracheoesophageal fistula and did have trouble with dose-limiting toxicities. So it does seem that you can't do conventional radiation and then SBRT as a boost, but why not just replace conventional fractionation altogether to the primary tumor? So our hypothesis, as opposed to delivering SBRT as a boost, will replace all of the conventional fractionation to the primary tumor with SBRT, and that can allow us 2 things. 1, because we're treating to a higher biological equivalent dose, we can improve local control that should drive a progression-free and overall survival benefit. And 2, because we're treating a very tight conformal area with SBRT, we're going to irradiate less lung. That can lead to less pneumonitis, less long-term fibrosis, and better quality of life for our patients. Plus, preventing progression will also lead to better quality of life for our patients. These are some representative cases, and you can see if we deliver SBRT to the primary tumor, you have very, very tight isodose lines around the primary tumor. Those isodose lines really bow in as you go to the nodes where you're treating the conventional radiation. Historically, you would almost see confluent lines, of the high-dose isodose lines connecting these dots. By treating in this fashion, you can see for the V40, for instance, it's 44% lower treating SBRT to the primary tumor than conventional fractionation to the primary tumor. Even the V20, which we know correlates with toxicities, a 30% reduction relative to conventional fractionation. So we really can make a dent in the lung doses with this approach. This is another clear example. You can see very nicely the isodose lines bow in so well, as opposed to high dose areas filling in this area and filling in this area as well. And by treating to these high biological doses, we can have dramatic responses that we really don't commonly see with conventional fractionation. This is a tumor that was treated by Josh's team. The treatment plan, very conformal, high dose, and you get a dramatic response post-treatment. So we wrote a phase 2 trial conducted at Atrium Health at Levin Cancer Institute. 61 evaluable patients were enrolled. This was recently presented as the highest scoring lung abstract in the locally advanced session at the ASTRO meeting this year. Patients had to have primary tumors up to 7 centimeters. Peripheral or central tumors were allowed, and they were treated with SBRT of the primary tumor in either 3, 4, or 5 fraction regimens, relatively pragmatic approach. They received then immediately following or in the days following mediastinal chemoradiation to all sites of nodal disease to 60 gray and 2 gray fractions, and then they were followed. Looking at the toxicity, this was reported in PRO earlier this year. Toxicity is very, very low. So out of 61 patients, there were no grade 4 or higher complications. As a comparison, on RTG-0617, 3% of patients did have a grade 5 event. And this is on the 60 gray arm of RTG-0617. Looking at grade 3 toxicities, only 1 patient had esophagitis, 3 patients pneumonitis. So very, very low numbers, much lower than we would expect. As a reference, in the 60 gray arm of RTG-0617, esophagitis was 5-fold higher at 7%, and pulmonary complications was more than 5-fold higher at 28%. Nicely, there were no grade 3 or higher cardiac events related to radiation in this cohort. And then, so toxicity is great, quality of life seems to be very good. What about the outcomes? And the outcomes look very, very good as well. At 1 year, the progression-free survival of the whole cohort, which was our primary endpoint, was 63%. Median progression-free survival is over 25 months. If you compare that again to the 60 gray arm of RTGO617, the median progression-free, the 1 year progression-free survival was in the 40% as opposed to the 63% that we had. Specifically looking at patients receiving durvalumab, since this trial started before durvalumab was FDA approved. So the first many patients did not get durvalumab, but then the last 26 did. The median progression-free survival in durva patients was 70%. So, excuse me, at one year it was 70%. Median was 26 months. That 70% compares very favorably to Pacific, which was only 58%. So again, if we can control the primary tumor better than we can historically, we can have better progression-free survival and better overall survival. That drove a median overall survival of our cohort to over 40 months. 1 year overall survival was 80% for the whole cohort, 85% in patients receiving durva. And SBRT did its job, just like we see in early stage patients. Only one patient had a local failure rate. So, really, really good outcomes, especially in these durva patients. So the trial that we now have used based on that phase 2 trial is LU008. Patients are randomized after diagnosis upon screening. They're stratified based on T stage and PD-L1 status. Patients have to have node-positive locally advanced non-small cell lung cancer. They're randomized either to conventional standard of care chemoradiation to all sites of disease, followed by maintenance immunotherapy, or the SBRT to the primary tumor, followed by chemoradiation to nodal disease, followed by maintenance immunotherapy. The SBRT is very pragmatic. All 3, 4, and 5 fraction regimens allowed in prior NRG and RTOG trials is allowed. Chemotherapy also very pragmatic. 1 of 4 options are available. And patients do not need to receive immunotherapy, and we have recommendations if it's elected that they don't receive immunotherapy. Inclusion is stage 2 and 3. They do have to have histologic confirmation of their disease. They have to have an identifiable primary tumor, so the very rare TX patients are excluded. Primary tumors can be pretty big, up to 7 centimeters for the treatment on this. Otherwise, the trial is very pragmatic, age 18 or higher, ECOG even up to 2, and then they can have induction therapy prior to enrollment, up to 4 cycles of any systemic therapy. The 2 exclusions are 1, centrally located tumors within 2 centimeters of nodal disease. So patients can have centrally located tumors, and we can certainly SBRT those. But if you have a centrally located tumor immediately next to a mediastinal lymph node, those patients are excluded. So likely 10 to 15% of our patients with locally advanced disease will be excluded because of that. And then patients can have prior in-field radiation, but if it's thought to impede study treatment, they can't. So, prior tangent breast fields or prior thymic disease or those types of things, or SBRT to a contralateral lesion, all those are fine. But, a locally advanced esophagus treatment probably would interfere with us. Objective is looking at overall survival as the primary objective, and then a co-primary objective is progression-free survival. Secondary objectives are looking at response rate, local control, patterns of failure, changes in PFTs, changes in quality of life, and we're using 3 tools, the FACT-TOI, the EQ5D5L, and the PRO-CTCAE, and then looking at acute and late toxicity profiles. And then we do have some neat exploratory objectives, looking at biospecimens, looking at regional lung ventilation and dose thresholds of ventilation associated with pulmonary toxicities, and then differences in outcomes and toxicities between protons and photons. Statistics, this is a hybrid superiority, non-inferiority design. So it's aimed at looking at overall survival in the SBRT arm being better than the control arm, or SBRT having essentially equivalent non-inferior survival, but progression-free survival being superior. We have a 90% power to declare non-inferiority, 70% power to declare superiority. We're expecting an improvement in 5-year overall survival from 38%, which is modeled based on the Pacific trial, in patients who actually can get durva, and from the time of initial randomization, up to 48% with intervention and improving local control and progression-free survival. We do have interim analyses to look for stopping. We have a total of 474 patients planned for enrollment. We need 450 evaluable patients. As I mentioned, there'll be interim futility analyses, and then also looking at survival. Accrual, we're expecting very conservatively 9.5 patients a month. I actually think we're going to do dramatically better than that. We've already seen very good accrual despite very few centers having the trial open to date. I think that's a testament to having about 120 people on this call already. We are doing central review as the planning can be complex for the SBRT patients. The first 3 patients of each treatment arm for each institution are undergoing real-time review. We are generally getting those reviews back within 24 hours, provided they're uploaded properly. So just ending with the timeline. So this was nationally activated in May, and we've already had accruals in July, several of them. So, some sites got it open within weeks of the national activation. We currently have 14 accruals of our plan 474, so ahead of schedule, given the fact that we weren't really expecting much in the way of accruals in the first 6 months after activation. Really nice to see that over 130 sites have the trial open already, which is pretty remarkable, and I thank all of you on the call for the interest in that. We have another 300 plus that have the protocol in submission, so we're expecting this number will continue to grow and grow, and therefore the accruals will hopefully take off pretty soon. And then lastly, just ending with this thought, if you haven't opened the trial and you're thinking about it, or you have competing trials, that may be okay. This trial is really, really pragmatic. It's certainly the most pragmatic thoracic trial in all of the NCTN. There's no lab cutoffs. As long as the medical oncologist thinks they can receive chemotherapy, that's okay. There's no diagnosis time cutoffs. So as long as they've had a CT chest and MRI brain that's negative, as long as they've had PFTs, there's no cutoff on PFTs values or when it's done. The only time requirement we have is they have to have a PET within 60 days of randomization, or excuse me, of enrollment. The trial allows ECOG2 patients. The trial allows people with targeted mutations, and you don't need to deliver durva in those patients. You can deliver alternative treatment approaches. You can have other malignancies as long as it's not thought to interfere with the safety and efficacy analysis, and you can do protons if that's of interest to you. The nice things, RTOG 1308 just recently completed accrual a little over a month ago. Congratulations to that study team. That was the only phase 3 trial in NRG space. The only other trial in all of NCTN that's open and locally advanced for phase 3 is the ECOG Akron 5183. That's actually expected to finish accrual this coming month in November. There are only 12 patients away from finishing. They've been treating around 20 patients or so a month. So there won't be any competing large locally advanced non-small cell trials across NCTN. So I hope you open and accrue to the study. So let me stop sharing there. I see a couple of questions in the chat, and then we'll turn it over to Josh to go over pragmatic studies. It asks, what about satellite nodules? And the answer is yes. As long as you can encompass it within your SBRT portal or your conventional fractionation portal, that is okay. They would be considered, in the same lobe of the lung. That's still a T3 lesion that's able to be treated. Allowing PS2 potentially compromises overall survival assumptions. Great point, Corey. Thank you for that comment. We have thought about this a lot. We do think the PFS ECOG2 patients are only going to be about 5 to 10% of patients, so it won't be a large number. That was something that was encouraged by CTEP. So certainly if you think that a patient can tolerate chemotherapy, do enroll them, but we do expect most of these will be ECOG 0-1 patients. All right, so with that, we'll go over some planning. Josh?
Okay, great. Thanks, Chuck. So I'll do a little bit of just practical review of one of the cases already enrolled. This is mainly because there are some differences in planning this versus conventional radiation for obvious reasons. There can be a lot of interplay with dose between the SBRT plan and the nodal IMRT plan. I'll introduce a little bit more of my team that'll go into specifics on the actual planning technique. And I think that will hopefully help some of the folks on the call who have had some questions. We've had a lot of emails about how to approach this. This is all very well described as well in our pro paper, which Chuck referenced earlier, so those slides will be available. That is actually being printed this month in the physical pro journal that's being sent out. So look for that as well. And it goes over a lot of what we're going to talk about today. So I'll start with a harder case, and then I have an easier case if we have time at the end, but I figured if we had time for only one case, we'll do the harder one. So this is a 69-year-old gentleman, just to set things up, who has a clinical T1C N1 stage 2B adenocarcinoma of the left lower lung. He was not a surgical candidate based on PFTs. And so he was seen by radiation oncology, medical oncology, and thought to be appropriate for combined chemo radiation. We discussed LU008, and he elected to enroll and was randomized to arm 2, which is the experimental arm with SBRT to the primary tumor, followed by conventional chemoradiation to the lymph node disease. So just, I think everyone can see my screen. Just to review, he has a primary tumor here on the PET in the left lower lobe, and then an adjacent hilar node. So very close proximity of the hilar node to the primary, as you can see there. So this is a very challenging case as far as potential dose overlap, which is why I wanted to discuss it today. So I'm going to review the contouring first. The contouring for this trial is pretty straightforward. We modeled it after previous RTOG trials. There are some key differences which I'll point out for the experimental arm that are different. I'm not going to go over the conventional arm. It is pretty much the same as far as margin expansions as previous trials have been, but if there are questions, we can certainly go over that. As far as setup and motion management, that's pretty well described in the paper as well. I won't go into great detail, but if there are questions, I'm happy to answer at the end. Essentially, we always encourage one CT simulation for patients and one planning scan whenever possible. That allows you to plan both the SBRT and the nodal IMRT plans on the same data set, which really helps to eliminate uncertainties with things like deformable dose fusion and things like that. So all of those techniques are how we treated the 61 patients on the phase 2 study. And I think, the careful planning techniques that we utilized are really why the toxicity was so low on that. So we want to replicate that for the NRG study, obviously. So I'll turn on some of the volumes. I'll start with the primary tumor volume, and I'm going to primarily look at this on the MIP. So again, this patient was set up free breathing with a 4D CT. So the first IGTV primary was defined on the actual ITV, as you can see here. So that is a pretty standard way of contouring as you would on an SBRT for stage 1. So defining your volume on the MEP, typically in lung windows, which I don't have right now, but typically the expansions or the contours would be defined on lung windows. So instead of that volume being expanded into a CTV, there's only one expansion for the SBRT portion of the planning, which is a 5mm expansion on that for your PTV. We elected to use a 5-fraction regimen for this patient. Typically, my approach for fractionation, which is not required by the study, but as sort of a suggestion, is that when there is no risk of dose overlap and we have a peripheral primary tumor, I typically use 3 fractions. If there is a risk of overlap, I use 4 or 5, and the protocol or the study does require 5 fractions for any central tumors. The nodal volume, again, is also defined very similarly with an ITV based on the MIP. I also use the contrast CT fused and the PET CT fused, as you typically would for a lung case. The expansions on this volume are going to be very similar to other RTOG or NRG studies. So typically a 5mm expansion to a CTV, which is shown in orange here, with careful cropping. So this is where I think we really crop out of central structures with our CTV very aggressively. So out of the central airway, out of the esophagus. In this case, you could even argue to crop it out of the great vessel and the heart as well. So aggressive cropping of your CTV, I think, is something that helps when you have dose overlap. And then as far as a PTV expansion, it will be a standard 5mm PTV expansion on this case. So if you look at the two PTVs together, you'll notice that there's a lot of overlap. So this is going to be a challenging case. We know that because of the dose interplay already being a factor, even just based on our volumes. I think that it's important, again, from a contouring perspective, really to make sure that you're cropping your CTVs well and enveloping your motion. Breath hold techniques, as well as other techniques to limit respiratory motion, are allowed, and I encourage those if necessary. It wasn't necessary on this patient, but we have used those techniques on other patients on the study. So I don't think we have any questions so far about contouring, unless we want to answer anything else. But if not, what I'm going to do is turn it over to Brian Kelly. Brian is a dosimetrist here at Levine Cancer Institute. He planned probably the majority of the cases on the phase 2 study. He's going to go over sort of approach from start to finish of planning. I think the most important thing he's going to talk about is a little bit of utilization of the dose from the SBRT plan as a base dose when you are planning your IMRT conventional plan to the nodes. That's probably not a familiar concept to a lot of people. It's basically allowing your VMAT or other planning system technique to consider the dose that's already being delivered as part of the SBRT when you are planning your conventional radiation to your nodes. We'll go over a little bit of how I evaluate those plans after Brian talks, especially when it comes to things like coverage of the volumes themselves, and how I sort of analyze that to kind of make these plans as safe as possible. So I'm going to stop sharing, and I will allow Brian to take over.
Okay, can everybody see my planning screen?
Yes, we can see it.
Okay, so I'll briefly go through the planning process. As Dr. Heisling said, these cases are the toughest ones that we plan with both PTVs overlapping each other. So when we first start planning these protocol patients, it's always best to start with the SBRT plan first. A lot of the planning concepts are going to be the same as planning any patient with multiple targets. But it's good to visualize both targets on the CT scan and kind of get an idea of the best way to treat the SBRT target while avoiding entrance those through that IMRT PTV. So for this particular case, you can see the mediastinal target is anterior to the SBRT lesion. So it's also good to be mindful of the large airway, esophagus, and the large vessels when determining the arc angles, since those are typically going to be the critical structures in the area that need to be kept as low as possible. Let me turn those on. So you can see they're all kind of right there together for these. So for this patient, we wanted to deliver the dose to the SBRT primarily from the lateral and the posterior direction to avoid that anterior PTV we're going to treat later on. So my first step usually is to start with I'll do a full arc to start out with. since it's kind of in the medial area, it's not all the way to one side, so we'll kind of start full, and then in the beam's eye view, you can identify the segments that would cause dose to transverse through that mediastinal target. So as the gantry travels around, you can see the beam as it would cause a more dose to go through that anteriorly. So in the optimizer, we could enter those gantry angles as a skip arc or a beam hold. And then, so for this case, here's a screenshot of what we treated. You can see the purple contours, the SBRT PTV. The red is the mediastinal. This yellow section of the arc designates the segments that are delivering dose, while the red is the beam hold region, avoiding dose through that mediastinal PTV. So since these PTVs overlap, once we combine the two plans into a planned sum, we know it's going to be a little warm in that overlap region. So we want to keep the SBRT global hotspot as low as possible. The optimization objectives didn't come over for this anonymized plan, but the highest priority would go on the SBRT targets. And then Eclipse has a avoid entry dose feature in the optimizer, which looks like this little arrow right here. And that's good to use on the mediastinal PTV to avoid as much dose overlap as possible. So we use that frequently. So we also use upper constraints on the mediastinal PTV, just like it's an organ at risk in the optimizer, to try to keep that dose to a minimum. The large airway, the esophagus, the large vessels are also critical OARs and will probably need a higher priority. We use two ring structures. We have a body minus PTV and a D2CM, which is a body minus PTV plus 2 centimeters. But with all these avoidances, we expect there to be some low dose bowing and bulging in those areas. And it's not going to be the typical conformality of a normal SBRT. So an attempt was made on this plan to keep the hotspot as low as possible, but because of this location sandwiched between several different OARs and that other PTV, this one ended up being 118% hot. Usually we try to get it closer to 110 if possible. So once I've optimized this plan, feel pretty good about it, the isodose lines, the hotspot, and the overall conformality, I'll go ahead and move on to the mediastinal plan. So traditionally with abutting and overlapping targets, dosimetrists used to create opti-structures with PTVs and OARs, but we started using base dose, which consists of entering the SBRT dose into the mediastinal optimization to account for the previously planned dose. We found that this method allowed us to achieve lower doses for the critical organs at risk. So using the entire SBRT dose plan as a base dose typically caused the mediastinal plan to have significantly lower coverage. So we began applying just a partial amount of SBRT dose into that base dose. So to do that, we'll duplicate the SBRT plan into its own plan, and then we'll just lower the total dose. And then use this as the base dose for that IMRT plan. So for this case, we decided that 35% of the base dose gave us the optimal amount of coverage and OAR sparing. So sometimes we use 25%, sometimes we went 45%. We've kind of been up and down, but we try to find one that works perfect for each patient. And then so setting up the arc angles for the this mediastinal plan is basically the same as the SBRT plan. We have two anterior arcs starting partially over the right side of the patient and traveling to the left side, avoiding entry through the SBRT that's posterior. And then here's a screenshot of both of our plans. So here's the SBRT arcs treating from below, and then we have the IMRT plan treating from the anterior angle, avoiding dose penetrating from through the other PTV on both. Optimization is similar to the SBRT, prioritizing the large airway, the esophagus, the large vessels, and using the SBRT PTV as an organ at risk to decrease the planned sum hotspot. So once we have both those plans created, we do the plan sum, and then we'll review this for the global hotspot. We have 10 gray for this plan sum. And then we'll review the organs at risk to determine if I need to go back and re-optimize either the VMAT, the mediastinal plan, or maybe I'll re-optimize both to try to get everything a little better. And at this point, once I think I have it the best I can, this is where I'll go back to Dr. Heiserling and we'll review it, and I'll get his input if we need to raise or lower this base dose for the VMAT, the mediastinal plan. And we'll adjust it from there. And I think Dr. Heisling's going to go over the coverages of this plan next.
Sure, you can go ahead and stop sharing and I'll reshare mine. Okay. There was a question about the eligibility of this particular patient. So Chuck went over the eligibility as far as a primary tumor within 2 centimeters of lymph node disease. That applies only to what we would consider the old definition of central base tumor, meaning it's within 2 centimeters of the primary bronchial tree. So this patient, when we measured that proximity, it was actually just over 2 centimeters away from the proximal bronchial tree. So that is why they were considered eligible. So hopefully that makes sense. So peripheral based tumors will often have disease within 2 centimeters, and that's allowed. And that's why we're kind of going over this case, because this is probably one of the best examples of that as far as trying to limit that overlap dose as best as we can. So there is going to be overlap dose, we know, but we're trying to make that as safe as possible. Okay, so I wanted to point out a few things on the actual plan itself. So unlike typical SBRT plans, we are going to have isodose lines that are going to look different than what we use in early stage non-small cell lung cancer, primarily from a conformality R50 and D2CM standpoint. So there are no requirements for R50 or D2CM on this study like we are used to looking for stage 1 SBRT. And that's so that we can shape isodose lines around our potentially overlapping targets, but also around our central OARs, and not have to worry about those. Those are good constraints for stage 1. They have purpose to compact dose, especially intermediate dose. But as you can see here, we have other priorities for this patient on the SBRT plan. You can see the blue isodose line is really shaping around 3 primary things. The spinal cord, the primary or large bronchus, and the actual overlap in the mediastinal target. So unlike a true SBRT plan, we're not evaluating those D2CM or R50. So when I prioritize what I want to see on the SBRT plan, the first is to meet coverage requirements. So we want to treat the primary tumor to the dose we intend. We want to meet the individual organ at risk constraints. So there are strict constraints for the SBRT plan. We also want to limit the dose as much as possible to the overlapping or adjacent PTV node, which you can see here. Brian's done a good job of that. There is always going to be some bleeding of that in, but what we want to do is really try to eliminate the overlap in the large airway, esophagus, spinal cord, things like that. The other thing I like to point out that's a big difference in these plans versus classic SBRT plans is we are not trying to quote unquote heat up the dose to the ITV. A lot of times in stage 1 non-small cell lung cancer, we try to get a big hotspot. We can see plans at 120, 130%. We like to do that to get even higher doses to the primary tumor. The strategy on this is almost the opposite. We really want to have cooler plans. We are already dose escalating in the stage 3 setting just by doing SBRT. So we really don't need to dose escalate with other techniques that whether it's negative blocking or other techniques to try to heat dose up to the primary tumor. I think Brian went over the base dose nicely. The range that we have used has been anywhere from 0.25 all the way up to 0.5. So, it's arguably a little bit of finesse as far as trying to find the exact percentage to use. But what we're doing is trying to balance what we can as far as coverage, but also, again, dose to the organs at risk. So here's the IMRT plan to the PTV node. And again, you'll notice a lot of what we're trying to do on this plan is lower the hotspot, especially to any of the central organs at risk. So I really want to see, as much as possible, less than 105% in some of our organs, whether it's the esophagus or large airway, the large airway being probably the most important in this setting. And then we want to, again, see limiting of the overlapping of dose with the primary SBRT target. I also like to limit the overall hotspot on these plans, much like we typically do with a locally advanced BMAT plan. And then the last thing is that the coverage, there are no coverage requirements for the individual plan in this setting, meaning there are no coverage requirements for the PTV nodal coverage from the individual plan to the PTV nodes. The only coverage requirements are based on the plan sum. So it is quite often, in fact, the majority of the time, we will be under, with someone that has an adjacent target, we will be under covering that target compared to what we're used to seeing. So for instance, the coverage on the ICTV nodal volume in this setting, 95% of it is getting 50 gray. Our prescription is 60 gray. Only 60% of our CTV is actually getting 60 gray on this individual plan. The reason we think that's okay is because there's contribution of dose from the SBRT plan. So when we look at the plan sum, we do have coverage requirements on the study that go over, that do require coverage requirements for the nodal volumes. And you can see that we're over covering the nodal volumes. If anything, we're still dose escalating in this patient beyond 60 gray, even to the nodal volumes. In fact, almost 100% of the nodal volumes getting 70 gray because of the degree of overlap here. So these plan sums are kind of what we want to look at as more of the evaluation than the individual plan. So I like to think of it as an SBRT plan, and then I look at the plan sum as sort of the total plan to the nodal volume. But you're going to see some scary isodose aspects to these overlap plans. For instance, the max dose on this plan is over 100 gray. There were several patients on the phase 2 study that had that. The key is not what the max dose is. There are some constraints in the trial that we are asking you to try to meet, but it's more important where that hotspot is. And so in this patient, we want that hotspot out of organs at risk. We want it theoretically in the lung, and we achieve that on this plan. So the max dose to the actual large airway was only 75 gray on this plan, which is what we kind of want to see. We want to see a dose that we think from a conventional standpoint is reasonable. So we will have some EQ-D2 constraints on the study for max doses to the large airway, the large vessels, the esophagus. They're already existing for the spinal cord. And there's some combined volumetric constraints for the lung as well. So that is where we want to really do a good job as far as planning, is to eliminate hotspots in those central organs at risk, and lower those doses as much as feasible, while still maintaining overall coverage on the planned sum.
And just speaking to the quote scary total dose, you know, we actually were more liberal on the phase 2 trial for what was included. And again, we saw so much less toxicity in a relatively large 60+ patient study than we've historically seen in our locally advanced patient population, because high point doses to tumor and to lung are not what's driving toxicity. It's high dose isodose lines into the center of the chest, which we can avoid with, you know, very precise planning. This is going to be one of the most challenging cases that you'll see, so that's why we wanted to highlight it, because central tumors are generally more challenging than peripheral, as you can imagine, and then tumors with nodal disease close to the primary tumor are more challenging, and this is kind of both. Even though technically it's not a quote central tumor, you know, the nodes are within millimeters of the primary tumor, so you're going to have a lot more dose contribution from the SBRT to the nodes and vice versa. So, you know, this is as hard of a plan as you'll see. We are going to have 2 examples of plans on the website of NRG, and that will help with planning. The PRO paper that's in press now, but will go to print in November, will also, once it's actually in print, will be on NRG's their CIRO website, as well as CTSU's website. So that will also be a guide, and Josh did a great job in that paper of really a how-to for the base dose, and you know, how you think through planning in different types of scenarios.
Yeah, I don't know that the second case is a lot easier, and probably will be the majority of patients. I'll just show it really quickly as an example of probably you know, not as challenging a case, but still some dose overlap that we had to do. But this is a peripheral primary as well with a level 7 node. I'm not going to show the details of the contouring again, but this is probably a better example of what the majority of the patients that will be enrolled on the study would entertain, which is, you know, not the use of base dose and things like that Brian went over, but just simply careful VMAT planning to try to limit that overlap as much as possible, and probably a lot more straightforward as far as planning goes with photons. And this patient didn't require a base dose. I think it was a lot easier of a plan, but I didn't want to scare people off with with the hard case, because that was a very difficult case. I think if we had done that as our first case ever, that would have been something we would have required a lot of help and assistance on. But I think going through it hopefully will help other centers. We're always available for questions, and we're happy to assist in planning. We are a multi-center site ourselves, so we've had many centers that haven't done this, that we've helped kind of get through that base dose technique and come up with very, very good plans. So it's achievable. It's different than what we used to do in locally advanced lung cancer, but it's once you do it once, it's pretty straightforward.
I mean, I think, of course, half the patients that you randomize are going to get just standard of care, what you're doing in clinic anyway. So it's, quote, easy NRG accruals. But, I think while this planning technique is different than what we're used to, I think we need different, because we really just are not doing well with our locally advanced patients. And unfortunately, us as radiation oncologists are a little bit losing this patient population to improvements in systemic therapy. And we're seeing medical oncology take more ownership in this patient population. But this is a population that we as radiation oncologists can cure, and we need to figure out how to optimize that. And I think higher dose, but higher dose delivered safely, not as a 74 gray conventional fractionation escalation, not as an SBRT boost, but as a smart way to do it, may be a very good option for our patients.
Yeah, and to add, this patient's already completed therapy and did great. Had essentially no toxicity. Didn't even have grade 2 esophagitis. And not only that, but these are the patients you love to watch on cone beam, because you treat them with SBRT and their primary tumor melts away during their fractionated radiation. So we're getting, impressive responses. Patients are tolerating the treatment well. Obviously, the phase 2 study was had great results. So I want to highlight that as well, that this is not a fake patient. This is a real patient on study that did very well.
And we haven't touched the potential for synergy between SBRT and the ultimate durva that they're going to be receiving afterwards. So, there are a lot of exciting aspects to the study, and some of that will be tested with our secondary objectives and exploratory objectives. So maybe with that, we'll open it up to questions. We still have 110 or 15 people on the call. Any concerns that sites have had on either accruing and questions about eligibility, on any early plans that have been done? We've had 14 patients accrue. We've certainly looked at all the plans. We've made sure that they're all safe, and that's our commitment, that we'll always get the plans back to you in quick time. The ACR and NRG team has been phenomenal, and really appreciate them and all their help during the central review process, and certainly as the trial got activated as well. So questions? All right, well, with that, I only see that we missed one question in the chat about how often are the quality of life assessments being tested. We do them before, one time during, 2 weeks after the completion of radiation, and then just at 3 time points after that. So late time points of 3, 12, and 24 months. And I do think that's going to be a big deal. I think we will, our hope is that we'll see an improvement in local control that will drive progression-free and overall survival benefit. But I think patients will hopefully notice an improvement in their quality of life by treating less normal tissue, having lower rates of pneumonitis as well.
I think there's one additional question, Chuck. May just need some clarification at the end.
How is using the physical dose, even if uniformity discounted, help in planning the conventional RT? And if it's iterative process, what is the benefit over calculating the maximum dose in EQD2? So we actually are going to add EQD2 to the protocol. I think that will be helpful to people, but we do have constraints for physical dose. I think that we are looking at overall hotspots, as Josh said in the planning. And I think it's easier to conceptualize for centers and probably implement for centers as well.
Yeah, I think the other aspect, so I think the EQD2 would help on your objectives. I don't know that it would help to allow you to undercover, but that I think it's a fair point that we can just maximize objectives as well. I think the physical dose actually helps the algorithm to kind of know where it doesn't need to cover the primary PTV, but there are probably other ways to do the same thing that we're trying to achieve here.
All right, so one last plug for any sites that don't have this open. Hopefully this worst case example didn't scare you off, but at least was a good guide. This recording will be available. The PRO paper is available to help plan. We're available. But this trial is really pragmatic. Again, the ECOG2s, any mutations, no cutoffs for labs or PFTs or anything. And really there aren't other competing trials in the NTCN space. So please do open it, and please do accrue. And we thank you all very much.
Thank you.
Congratulations, Chuck, on your speedy accrual.
Thank you.